الرحمن الرحيم والحمد لله رب العالمين. أنا سبق واتكلمت عن I had already spoken before about what we call the clinical mentality and the importance of mentality in the clinician's professional life, that is in clinical practice. ودي اللي بنسميها العقلية الإكلينيكية. العقلية بصورة عامة للإنسان مهمة جدا في حياته، لأن عقليته هي أساس حياته، the mentality، وهي اللي بتظهر في صورة البيهيفير والأكشنز والاتيتيود، and it affects his or her lifestyle. the mentality، العقلية هو ده أساس كل شيء، لأن زي ما سبق وقلت قبل كده إن the mind is everything، العقل هو كل شيء. وزي ما سبق وقلت إن life is a mindset، إن الحياة هو نظام عقلي، هو عقل مرتب. Life is a mindset and the mind is everything، والعقل هو أساس كل حاجة في الحياة. وده بيظهر فيه and this appears in what we call the mentality of the person's mentality. And let me talk in particular about the clinician's mentality أو clinical mentality، العقلية الإكلينيكية، because this is the pivotal issue in the clinician's professional life or in the doctor's professional life, whether the doctor is a physician or a surgeon. It is very important to focus on how is your mentality working. How is your mentality? This is very important. وجزء من الكلينيكال mentality هو ما نسميه بالhigh index of clinical suspicion. High index of clinical suspicion. The good clinician and the wise clinician should always have a high index of clinical suspicion، اللي احنا بنسميها الشك الإكلينيكي. يعني he thinks about many possibilities. He should not look into the clinical case with a telescope. what we call the telescopic vision، ان هو بيبص على الحاله الاكلينيكيه اللي قدامه كما لو كان بينظر في تلسكوب، يعني narrow vision. لا، he should have a broad mind. He should have a broad clinical suspicion. وده مش هيجي غير لو كان and this will not come unless the physician or the surgeon, that is the clinician in general, has a wide spectrum of clinical knowledge and has a wide expertise or experience in clinical practice in his or her field. This is very important to observe the high index of clinical suspicion. وبما ان في حاجه اسمها هاي اندكس اوف كلينيكال سسبشن، يدخل في هذا الموضوع اللي هو الشك الاكلينيكي او الهاي اندكس اوف كلينيكال سسبشن، زي ما بنقول ان يكون عند الفيزيشن هاي اندكس اوف كلينيكال سسبشن ويحط برود ديفرنشال دايجنوزس قبل ما يوصل للديفينيت دايجنوزس او الفاينل دايجنوزس. في بيحط بروفيشنال دايجنوزس وفي ديفرنشال دايجنوزس، وبعدين at the end بنصل إلى before arriving to the definite and the final diagnosis. Provisional diagnosis, differential diagnosis, and final or definite diagnosis after investigating the case, of course, by all types of investigations: laboratory, pathology, endoscopic, radiologic, etc., etc. Among this topic of clinical suspicion is what we call the pseudo presentations in clinical practice. وهنا, and here I will come to this is the main topic of my speech today, but I had to introduce it by this what I mentioned before and what I started my speech with it. That is the clinical mentality and the high index of clinical suspicion. So now I come to the main topic and the exactly to be to the point, as we say, what is the pseudo presentations in clinical practice, which is my topic today. So today I will speak about the pseudo presentations in clinical practice. What is pseudo presentations in clinical practice? That is the false presentations of some clinical symptoms and signs, what we call false presentations or pseudo presentations in clinical practice. Like what? Pseudo presentations or false very common, so as not to be confused with the true presentations, whether symptom or sign or symptoms or signs. For example, we have what we call the coma and pseudo coma. Coma is unarousable unconsciousness. Unarousable unconsciousness. And it is the worst degree of loss of consciousness or disordered level of consciousness, because as we all know, consciousness has two components, level and the content. Disturbance in content, we call it confusion. Disturbances in level, we call it unconsciousness, with all its degrees. From drowsiness, passing to lethargy, and then to stupor, and then to semi-coma and coma, as we always say in the traditional clinical medicine. So, coma, it is unconsciousness, unarousable unconsciousness. يعني اللي بنسميها, we call it in Arabic غيبوبة. شخص في غيبوبة. He is totally unconscious, that is unaware. And this unawareness is unarousable, that we cannot get the patient up or arouse the patient or awake him up from this unconsciousness, this pathological sleep, by any stimulus, whether it is painful or physical or motor or verbal stimuli. So this is what we call the coma. It is unarousable unconsciousness. فقدان كامل للوعي, غيبوبة. The differential diagnosis of this is the true coma, but we have what we call pseudo coma, and pseudo coma is what we call the logged-in syndrome. So the logged-in syndrome is the pseudo coma. We call it sometimes pseudo coma. What is the logged-in syndrome? The logged-in syndrome is that the person is fully conscious and aware, but he or she is completely paralyzed, except for eye movements. But the patient is completely paralyzed. So the main symptoms or the major symptoms of the logged-in syndrome are quadriplegia, that is complete paralysis of all the limbs, no motor movements at all. And there is what we call inability to speak, or anarthria, that is inability to speak. لا يتكلم على الإطلاق هذا الشخص. So he is completely paralyzed and unable to speak. But there is preserved hearing and preserved cognitive function and preserved eye movements, as represented by vertical eye movements and the blinking of the eyes. وبالتالي الشخص ده ممكن يبربش برموشه بعينيه، يعني في some eye movements وفي vertical movements of the eye. فدي preserved eye movements and preserved hearing and preserved cognition, but the patient appears to be outside the world totally. Why? Because completely paralyzed and unable to speak. And this person in the logged-in syndrome can communicate through eye movements. And certain other actions. يقدر ان هو يكوميونيكيت مع السراوندينجز من خلال حركات عينيه. الشخص اللي هو بيعاني او اللي في حالة logged-in syndrome can communicate in a way or another, mainly through eye movements, because there is preserved eye movements, there is preserved hearing, and there is preserved cognition. But there is no thinking, there is disturbed thinking, there is apparently unconsciousness, although the patient is opening his eyes. But he looks as if he is unconscious. That's why we call it pseudo-coma. But this person is different from the true coma, in that the patient is in fact able to communicate with the surroundings by eye movements, especially by blinking and vertical eye movements. Unlike the true coma, in which the patient is unable to communicate at all, and there is no eye movements, and there is nothing. And he is unaware, and he is unarousable. This is the true coma. But this is not the real issue in the pseudocoma or in the logged-in syndrome, as I mentioned. And also, what are the causes of this logged-in syndrome? It's usually due to problem here. The pathology is in the pons, in the brain stem. This locked-in syndrome, its cause is a pontine lesion, is a brainstem lesion, to be more precise, in the pons. يبقى هنا مكان الباثولوجي anatomically is in the pons، والبونز بقى احنا عارفين هو جزء من البرين ستيم اللي هو بيتكون من الميد برين والبونز والميدالا اوبلونجاتا. So there is pontine pathology like pontine tumor, pontine trauma, in cases of head injury or head trauma or likewise, and also in pontine strokes or brainstem strokes, bleeding in the brainstem or ischemic stroke affecting the brainstem, especially the pons. It will cause or it will result in the patient suffering from locked-in syndrome. This locked-in syndrome with quadriplegia and inability to speak. But the patient is still able to communicate in a way or another, as I mentioned, by blinking and by vertical eye movements. So this is pseudocoma or the locked-in syndrome. Let me shift to another pseudo presentation in clinical practice, which is the pseudo syncope. We all know that syncope is transient loss of consciousness, from which the patient is able to get up. So there is transient loss of consciousness and collapse to the ground. This is the clinical picture or the clinical presentation of this clinical symptom, which we call it syncope. So syncope is transient loss of consciousness and collapse to the ground. مريض بيسقط لتحت ويسقط ويفقد وعيه تماما for few minutes, and then he gets up and wake up and get up. And this doesn't pass or doesn't exceed 10 to 15 minutes maximum in the transient loss of consciousness and collapse of the patient to the ground. This is what we call collapse to the ground or a collapsing patient. Fall down. Syncope with its two main divisions, the cardiogenic syncope and the neurogenic syncope, اللي هي الأسباب الرئيسية يا إما أسباب cardiovascular يا أسباب من النيرفس سيستم, neurogenic causes of syncope and cardiogenic or cardiovascular causes of syncope. The two major groups of syncope etiology or syncope etiology. So this is syncope, but we have this is true syncope, but we have what we call the pseudo syncope. Pseudo syncope is like what a coma and pseudocoma. Pseudo syncope is that the patient looks as if it is a syncope, but it's not a true syncope, it's false syncope. What are the causes of pseudo syncope? We have drop attacks, which is a type of epilepsy, petit mal epilepsy. Drop attacks looks like syncope, so it's considered in the differential diagnosis of true syncope, and we call it pseudo syncope. So drop attacks, epileptic attacks, precisely, and especially the drop attacks. This is a type, we all know that petit mal present with drop attacks, akinetic seizures, and the other subtypes. But the most common is the drop attacks and the akinetic seizures and the absence seizures. So it's a type of seizures. And the seizure is general term. One of its types is epilepsy, because we have what we call epileptic seizures and non-epileptic seizures. And the seizure, it is due to abnormal electrical disturbance of the brain presenting with motor, sensory, or autonomic symptoms and signs. So it presents with somatic or with autonomic presentations. This is somatic epilepsy, motor and sensory, and autonomic epilepsy, as we all know. And the epilepsy is a type of seizures, because not every seizure is epilepsy. We have what we call non-epileptic seizures, as I said in one of my clinical lecture series before. But every epilepsy is a seizure attack. We have what we call pseudo-seizures. Pseudo-seizures, pseudo-syncope, is that the patient collapse, there is transient loss, but it's not a real syncope, which is attributed to cardiac or neurogenic causes. It is other diseases, other pathology, like what, doctor? Like the akinetic seizure. So akinetic seizures or drop attacks, they present like syncope, but it's not syncope. Number two, hypoglycemia can be one of the causes, is one of the causes of pseudo-syncope, because also the patient might collapse to the ground, especially in acute hypoglycemia in diabetic patients. So pseudo-syncope is one of the presentations of hypoglycemia, and it is considered among the causes of pseudo-syncope, hypoglycemia. Also transient global amnesia, also sudden cardiac arrhythmias, also hysterical conversion attacks in hysterical patients as a psychic cause, which might simulate syncope, but it is pseudosyncope. So pseudosyncope might be psychogenic in hysterical patients. In hysterical patients suffering from hysterical neurosis. So this is called pseudosyncope. Also, we have in the seizures pseudo-seizures, that is not real seizures. In epilepsy, we have pseudo-epilepsy, that is seizures, but not real epilepsy. Like the seizures which happen with fever, febrile seizures or febrile convulsions, the post-traumatic, hypoglycemic, arrhythmias. This might all cause seizures, but this is not a real epilepsy. We call it pseudo-epilepsy. Whether it is presenting with motor manifestations like convulsions or like sensory epilepsy or autonomic, and the convergence, whether it is tonic or clonic. So this might present with a picture with what we call pseudo-epilepsy. So this is pseudo-epilepsy. So beware of the pseudo-epilepsy versus true epilepsy. And I mentioned some of the causes of pseudo-epilepsy. And the pseudo-seizures also the same. And among the pseudo-seizure is the non-epileptic seizures. Which might present in patients with hypoglycemia or psychological cases or psychic patients, that's psychogenic. So this is also considered among the causes of pseudo-seizures. And also patients with transient global amnesia or the TGA, which is a neurological dysfunction. We call it transient global amnesia. So this is what we call some of the causes of the, and also to be mentioned, the gynecomastia versus true gynecomastia versus pseudo-gynecomastia. True gynecomastia is enlargement of the glandular tissue of the breast, causing enlargement of the breast or breast hypertrophy in males. Gynecomastia, enlargement of the breast in male, whether it is unilateral or bilateral, it is gynecomastia, and it, as we all know, the etiology of gynecomastia is multiple. Whether it is physiological, like in geriatric gynecomastia, or in malnutrition, or in patients in drugs which cause gynecomastia, or tumors which might be associated with gynecomastia, or some local neoplastic diseases of the male breast, or malnutrition, or some other endocrine diseases causing gynecomastia, as happens in Klinefelter syndrome. And so there is causes of true gynecomastia versus pseudo-gynecomastia, which is a male patient having enlargement of the breast, but not due to enlargement of the glandular tissue. It is due to enlargement of or hypertrophy of the adipose tissue of the breast, whether it is hypertrophy or hyperplasia of the adipose tissue of the breast. And this is what we call the lipomastia or adipomastia. That is the only thing is just enlargement of the fatty tissue. It's not the glandular tissue of the breast. Because we all know that the breast consists of glandular tissue anatomically and fatty tissue. That is fat, that is adipose tissue, especially under the skin. So there is glandular tissue and fat, or adipose tissue. When there is enlargement of the adipose tissue, we call it adipomastia. When there is enlargement or hypertrophy of the glandular tissue, that is the glands, the mammary tissue, that's why we call it the mammary gland, which in females secrete milk, and also maybe also in males with prolactinoma, for example. So there is galactorrhea. So this is the mammary tissue of the breast. When the mammary tissue is enlarged, the glandular tissue, that is the mammary tissue of the breast is enlarged, we call it gynecomastia with all its causes. This is true gynecomastia. But if it is due to enlargement of the adipose tissue, this is adipomastia or lipomastia, which might be confused with true gynecomastia. So there is gynecomastia true and pseudo-gynecomastia, which is the lipomastia or adipomastia of the male breast. Be careful also in this issue. So these are just few of the pseudo presentations in clinical practice, as I mentioned: the pseudo coma, the pseudo syncope, the pseudo epilepsy, the pseudo seizures, the pseudo gynecomastia, also pseudo diabetes. In non-diabetic hyperglycemias, we call it pseudo diabetes, because not every hyperglycemia, as we all know, is diabetes. So when there is hyperglycemia, as it happens in patients with subarachnoid hemorrhage and patients with acute cardiovascular causes, catastrophic causes like dissection of the aorta, or we get what we call hyperglycemia and glycosuria, but this is not real diabetes. We call this false diabetes because it is non-diabetic hyperglycemia. So we have false diabetes also. Thank you so much, Professor Dr. Tarek Ali.